Hey guys, thank you for tuning in to fmQUICKIES. Today we'll be talking about anaphylaxis. Something I think a lot of professionals are going to see, ranging from being in an outpatient clinic to emergency department to being in a interventional radiologist, someone allergic to contrast. So what is it? Basically, it's a extremely serious allergic reaction, potentially fatal reaction. Um, when someone's exposed to an allergen, resulting in a hypersensitivity reaction that may cause the picture below here. It affects up to 2% of the population, and it is one of those conditions that is often underdiagnosed and undertreated, especially at those that are highest risk. Who do I mean by that? The children and adolescents. Uh, Anaphylaxis is also one of those conditions that we can fix, so it's definitely good to pay attention to what it is and how to diagnose it and treat it. So classically, when we think of anaphylaxis, we think of people with welts over the body after eating peanuts and possibly some wheezing. But it could occur without skin symptoms, as we'll show you guys in the diagnostic criteria. Most of these reactions are triggered through the IgE response. In children, food is the most common trigger, and in adults, insect stings and food is the most common triggers. Alright, the diagnostic criteria. So there are three diagnostic criteria. The first one involves the skin, the mucosa, and either the respiratory compromise or hypotension. So skin and mucosa. So skin obviously having hives on their body. Mucosa, you look at their lip, look at their tongue, and you also look at the uvula for any swelling. Respiratory compromise, you're looking for a patient with dyspnea, they're on a tripod position, wheezing, bronchospasm, stridor, or even hypoxemia. With reduced blood pressure, you look for someone much lower than baseline systolic blood pressure. Um, and associated dysfunction includes hypotonia, syncope, or even incontinence. For the second criteria, we're looking for two of the following after exposure to a likely allergen. Two of the following including skin, mucosa involvement, respiratory compromise, reduced blood pressure and associated symptoms like I mentioned earlier, and GI symptoms. The third criteria is a reduced in blood pressure after exposure to a known allergen. So, as you can see from the third criteria, like we mentioned earlier, you actually don't need skin involvement to be diagnosed anaphylaxis. A thing to note is that 90% of anaphylactic reactions do involve skin and mucosa. So 90% of the anaphylactic reactions will most likely meet the first criteria. Here's a table I found in the allergy immunology journal of some sort. I'll have the reference below and a link below for you guys to look up if you're interested. So what kind of lab tests can we do? One thing is that we can order tryptase or plasma histamine. But just remember, this is a clinical diagnosis. If you're really unsure, you can order these tests. They will come back probably in days. And it's probably something you can do in the meantime while twiddling your thumbs. So, what are the immediate managements with anaphylaxis? So, first thing is remove any antigen that's causing the anaphylaxis. If there's any medication, IV drips, stop it immediately. And pharmaceutically, you give them epinephrine. If you're diagnosing someone with anaphylaxis, there's really no absolute contraindications to epinephrine. An adult dose is 0.3 to 0.5 milligrams intramuscularly. Now, I want to talk to you guys about the concentrations because this is not universal in every hospital, and there are multiple case reports you can find online about people giving wrong doses of epinephrine, causing more harm than good. So 1 in 1,000 means for every 1 milliliter of fluid, there's 1 milligram of epinephrine. So if I wanted 0.3 milligram of epinephrine, I would draw up 0.3 milliliters. In a 1 to 10,000 concentration, that means I have 0.1 milligrams of epinephrine for every milliliter. So I would actually draw up 3 milliliter of epinephrine. To give it, we go for the mid-outer aspect of the thigh. There's been studies that shown that if you give it via thigh instead of the deltoid, you would actually have a higher peak epinephrine concentration in your serum instead of the deltoid. We never give epinephrine initially for anaphylaxis IV unless they're very severely ill, because there's a risk of arrhythmias and cardiovascular side effects of epinephrine, obviously. Other things you can do is place the patient in supine position, elevate their lower extremities to increase their venous return, and put them in a recumbent position if they're vomiting, protect their airway. Give them supplemental oxygen. You want to put a non-rebreather on them and crank it up to 6 to 10 liters. And also give them an IV bolus as well. Now, other management we do with someone with anaphylaxis is H1 blockers, Benadryl, and also H2 blockers like ranitidine. Now, make note that these are other managements because these are not crucial like epinephrine, and these H1 and H2 blockers actually basically just help with the rash they have and help with the hives. It doesn't really help them with their wheezing. It doesn't help with their cardiovascular compromise. And of note, if someone has a really low blood pressure, H1 blockers can actually make it even lower. You can give them albuterol nebulizer if they're having wheezing, and also give them some glucocorticoid like methylprednisolone. You give them 1 to 2 milligrams per kilogram per day. The idea between giving them some steroid is you prevent any re-exacerbation. You prevent any re-exacerbations. Now, like I mentioned earlier, if someone was not responding to the third dose of EpiIM, and they were still severely hypotensive, wheezing, and they look really bad, you can start an epinephrine IV drip. Start it low, 2 to 10 mics per minute, and crank it up as well. So here are my references. Alright, well, thank you for tuning in.